Dr. Yu Wu from the State Key Laboratory of Brain and Cognitive Science, Institute of Biophysics, Chinese Academy of Science, Beijing. Please go on.
Okay. Hello, thank you for introduction. It's truly an honor to present our work here. I'm Yue Wu, a 6-year PhD student, and our work is about using the modified echoplanar imaging sequence for fast cerebrovascular imaging. As many of you experts well know, time-of-flight TOF and susceptibility-weighted imaging SWI are fundamental techniques for angiography and venography. However, the mainstream of these acquisitions are based on GRE sequence and limited by the relatively long scan duration. In contrast, echoplanar imaging is fast, and recently it was reduced to for acquisition of MRA or MRV separately. But in our practice at 3 Tesla, it suffered from severe artifacts because EPI itself is prone to such as off-resonance, motion, physiological noise, and has Nyquist ghost. So another way for acceleration is in the previous works about simultaneous MR angiography and venography. These techniques were based on the multi-echo version of GRE, so it is still inherently limited by the low speed. So in this study, we proposed DEPSIV, a modified 3D multi-shot EPI for simultaneous MR-AV acquisition. We needed to modify the EPI sequence to meet the requirement of MRA and MRV. And also, we have to overcome many various artifacts coming with EPI. So this is a regular EPI with linear reordering. Since angiography and venography both needed flow accommodation, we firstly modified the prephasing block, rephasing block of echo 1 and prephasing block of echo 2 so that it can achieve first-order gradient moment nulling at the effective TE point. This gradient was designed based on the analytic solution at start point and the grid search for duration optimization. Meanwhile, TOF is based on the contrast between the fresh blood and the saturated tissue. The fresh blood requires a relatively short TE, and the saturation requires a relatively short TR, neither of which it was met with conventional EPI because of the long echo train, of course. So we use center-out trajectory. The filling of K-space starts directly from the center of K-space, so the effective TE is as short as possible. And now, echo train does not influence the TE effective. Also, the center segment was designed to be oversampled twice so that it may provide supplementary information. This overlapping data makes it possible to reconstruct data from each half K-space from the perspective of partial Fourier. However, the use of CO trajectory is not free. It comes with costs. It introduces more complex artifacts. We analyze this by deriving the analytic point spread function, PSF. But the major challenge of using the center-out trajectory we found, plus the multi-shot acquisition, is the introduction of numerous discontinuities in the K-space, which disrupt the smoothness of the modulation function. And then, after the Fourier transformation, in the image domain, it has a much more complex, highly complex point spread function. And these side bands indicates the presence of artifact similar to splitting. I will show it later. So we incorporate a reconstruction workflow to deal with this problem. It mainly consists of we first combine all the short data based on the after the linear and constant phase correction based on the overlapped line as self-navigation in the center segment. The images of two half K-space with opposite phase encoding direction, AP and PA, can be used to estimate the of-resonance map, the dirt B0 map, and delta B0 map via FSL top-up. And then we combine these informations all together, and we use a joint reconstruction with Masow's low-rank regulation to handle the short-to-short phase variation typical for multi-shot acquisition. And the joint reconstruction is here. The off-resonance term is explained in the L2 norm, and the Masow is used as the nuclear norm. We solve it with a very classical POX algorithm with singular value shrinkage. And we evaluated depth safe with phantom and human at 3T, but temporarily at a relatively low resolution. So in the slice of ACR phantom, you can see that the edges of grid are split into two lines. These are the so-called split artifact typical for centric out reordering. So after the correction, there is no obvious artifact. Another slice, the artifact is so strong that it causes blur of the margin and also the dot array. It's typical for 0.9 resolution. Also, the reconstruction has solved such splitting artifact. From this image of first echo in vivo, small arteries crossing through the plane and the perivascular space can be clearly depicted by depth safe, but not on the original image. Also, in the second echo image, the image is sharper, and the small medullary veins can be seen on the depth safe image, and also the off-resonance induced artifact is reduced. This is a comparison of results between DepthSafe and the GRE. The depiction of vasculature is similar, but the scan time of DepthSafe is largely reduced. With larger slice coverage, the almost whole brain MRA and MRV can be acquired within 3.5 minutes. And however, the ghosts around the large vessels remain a significant issue. Lately, we've discovered that it actually originated from an inherent flaw in the flow combination of EPI readout. The even and odd echoes in the echo train naturally have different flow-related phase, and it's periodic. So this actually resulted in periodical modulation across the K-space, and so the bad artifact will turn out, especially around the large vessels with large phase flow-related phase. So our PSF analysis will tell us that too. We modified the sequence, reorganized data, we developed some method, but I'm afraid this section is beyond the scope of this today's short presentation. Based on this physical hypothesis and principle, we have made this happen. We detected the artifact and we corrected it. So this is called a CO3 version of DepthSafe. Sorry, I ignored many technical details, but in summary, we presented DepthSafe. We use EPI for fast acquisition of simultaneous MR angiography and venography, and preliminary results show that we can achieve whole brain acquisition of MRA and MRV within 200 seconds. And please feel free to discuss more and later. Thank you very much.
Thank you, Dr. Yu Wu. Are there any questions? Please, Michael.
Thank you for a great presentation and obviously highly complex technical developments that you've been doing for this technique. I have a question regarding the arterial depictions of the vessels. You showed some comparison of a regular time of flight angiogram and your technique. Can you comment a little bit more if you had a chance to evaluate about the diagnostic accuracy of your technique compared to a standard technique?
I'm sorry, could you explain this question?
Did you compare your technique to a standard time of flight,
yes.
for example? And you know, when a radiologist looks at both techniques, what's the feedback?
Yeah,
you get?
this is a working in progress. By the time I made this PPT, this only has images. But after I have made the quantitative comparison of both SNR, CNR, and more in veins and arteries and deep gray nucleus to compare this with GRE. And also, I have invited two neurologists to compare the image quality. These primary results came that the CNR is lower because the acquisition is fast, and but the image appearance of veins and arteries made scored by the neurologists say is similar. So the lower SNR basically does not affect that much.
All right, thank you.
Thank you very much. Let's move on to the next. Dr. Danny Wang, coming from the Stevens Neuroimaging and Informatics Institute, University of Southern California. And we will hear about vessel density mapping of cerebral small vessels on 3D high-resolution black blood MRI. Please go on.
Good morning. Thank you. Thank you for the introduction. So the previous two speakers laid the ground for this my talk. So we switch a little bit into more small vessel imaging. So the goal is try to diagnose cerebral small vessel disease. So cerebral small vessel disease is actually the main cause of vascular dementia, and it occurs with Alzheimer's disease. And so far, there's no established imaging technique that visualize them or quantify them. So radiologists using the parenchymal markers, such as the infarct and the white matter hyperintensity, Lacunes, and enlarged PVS, as well as microbleeds. But these, it's a late markers and represent parenchymal changes. So usually we know the 70 TOF is kind of reference standard to image small vessels such as lenticular striatal artery and some diving arteries. And so what we have been doing in the past 5 years is really try to find a new use of the black blood, T1 weighted space, T1 weighted variable flip angle turbo spin echo to image black blood small vessels. They actually can see more, as you can see, even at 3T compared to the 70 TOF. So we published a paper in 2019. We optimized the protocol for small vessel imaging. We compare 3T 70 with black blood with the 70 TOF in young and aged subjects. And we did a manual segmentation. As you can see, we can identify more small vessels compared to 70 TOF, both at 3T and 70, and we can identify the age decrease of the vessels. So today's work was just a continuation. So we developed a semi-automatic pipeline, try to do whole brain imaging of the small vessel density. So it includes several steps, denoise, skull stripping, and then vessel segmentation, then vessel masking and co-registration with NP-RAGE, then identify the small vessel density. So first step, we did synthetic data. So we tried to test 3 Haitian-based small vessel filters. One is called Jimin, one is called Fringe, one is called Seto. So with different noise levels, so you can see the Jimin has the robust noise resistance and also the best vessel response for both small and large vessels. And then we did in vivo data. This is using manual landmarking, 2,000 points within and 2,000 points on the background, and then we tested the RC curve. So the Jimin also has the best accuracy, and you can see, the identified vessel is mostly uniform and continuous with the Jimin in both young and aged subjects. This is actually RSA because we actually have fellows tediously label them. So we have the ground truth. And you can see, again, Jimin has the best accuracy, as well as we have this average dawn. This is Hansdorff distance. And so the Jimin filter was the best in terms of, the accuracy, minimize the false positive and false negative. And then with this technique, so we can see, we apply on aging. This is young and this is aged subjects. So globally, we can clearly see, the vessel density is sparse. And it's a small, reduce the global vascular volume. And also, we can smooth them. Then we can get to the whole brain regional measure of vascular density. Normalize them, and then we can look at the regional difference. So this is aging effects. As you can see, these are posterior cingulate, parietal, frontal. So these are all very cognitively relevant areas. And also we did a correlation with composite executive scores and the MoCA global scores. They all show very nice correlation with PCC, parietal, and the frontal, as well as medial temporal, in a very small sample, so it's very encouraging. So recently, we have been optimizing the protocol together with Professor Fan. So this one is slightly longer. It's ISO 0.5, but 9 minutes. So we made it sharper compared to the vessel word imaging protocol. So we're getting for the whole brain coverage. So to summarize, so this is a new use of the T1 weighted TRC-VFA with high resolution. We developed a semi-automatic pipeline for quantification of small vessel density with nearly whole brain coverage. And we have an ongoing study to apply in multi-ethnic population in Los Angeles. Thank you very much, and the collaborator and the funding support. Thank you.
Thank you, Dr. Wang. The paper is open for discussion. There is a question, I see.
Yeah, nice talk. So, Danny, do you think this small vessel density is correlated with blood volume? So, if it is, then why I don't see the contrast between gray and white matter?
It is actually much denser in gray matter. Yeah, I think the angle, I can show you different angles. It looked like a perfusion if you smooth.
Okay.
Yeah.
Thank you. And let's move on with the next talk. This is given by Dr. Da-Pang Liu from Department of Radiology, Johns Hopkins University School of Medicine, Baltimore, Maryland. Angiographic comparison of different velocity selective labeling modules directly on cerebral arteries. Please go on.
Hi, thanks for the introduction. My name is Chen Chen from Johns Hopkins University. This work was mostly performed by Dr. Da-Pang Liu of my group, but unfortunately he could not be here presenting himself. So a class of pulse streams applying flow-sensitive gradients can be categorized as velocity-selective modules, or VIS modules. And black blood MRA, subtraction-based bright blood MRA, and non-subtraction-based bright blood MRA have all applied with VIS pulse streams, including MSDE, FSD, which is a flow-sensitive dephasing, DANTI, and FT-VSS or FT-VSI, which are Fourier transform-based velocity-selective saturation or inversion pulse streams. For VS-ASL-based quantification of blood flow, blood volume, or venous oxygenation, MSDE, DANTI have been used for flow crushing. And DRHS, DRHT, which are double refocused hyperbolic secant or tangent pulse streams, or BER8, which is 8-segmented B1 insensitive rotation, which are sort of apply the adiabatic refocusing pulses to achieve minimum susceptibility to B0, B1 field inhomogeneity and eddy currents. These have been used for VSS labeling. And FT-VSS and FT-VSI have also been demonstrated for labeling as well. So this study aims to evaluate the labeling characteristics directly on various cerebral arteries using VS-MRA of different VS labeling modules, including 5 pulse streams, DRHT, BER8, DANTI, FT-VSS, and FT-VSI. Here are the parameters and the sequence diagrams of these 5 VS labeling modules. They all matched at the cutoff velocity of 2.0 centimeter per second. And for the DRHT, it's a 24 millisecond duration with 5 millisecond hyperbolic tangent refocusing pulses with a 17 millitesla meter gradient strength and 1.0 millisecond gradient duration. The BER8 is also 24 millisecond, 3 millisecond HT refocusing pulses, and 30 millitesla per meter, 1 gradient strength and 1 millisecond gradient durations. And DANTI is a 40 millisecond duration with 40 segments of 1 millisecond each, and 21 degree flip angle, and 59 millitesla per meter strength, 0.8 millisecond gradient duration. And for the 2 FT-VS pulse streams, it's a 64 millisecond duration with 8 segments of 8 millisecond each, and 1 millisecond composite refocusing pulses, phase cycling, and 21 millitesla meter gradient strength, 0.6 millisecond gradient duration for the gradient lobes. So for all VS modules except Fourier transform FT-VSS, the controls were with gradient amplitude turned off were acquired as well. And so the first column here are the simulated MZ velocity response of label, control, and their subtractions, which are displayed at the third row for each of the 5 VS pulse streams used in this study. The second column are the corresponding results after the laminar flow integration with the x-axis as the mean velocity of vessels. Note that DRHT and BER8 share the identical VS profiles as the conventional VSS pulse streams, which is to dephase flowing blood above the cutoff velocity. FT-VSI had similar VS profiles as FT-VSS, but with idealized magnitude difference of a factor of 2, with the flowing blood signal in the pass band and static tissue signal in the saturation or inversion band. The DANTI would produce slightly lower label control subtracted signal than DRHT and BER8 due to the averaging of the well-known spatial banding effect from the SSP-based pulse streams. So all experiments were performed on Siemens Prisma scanner with a 20-channel head-neck receiving coil. 5 healthy subjects were recruited. The VS-MRA sequence here consists of 3 modules. The VS label control module applied here, and spatially selective inversion adiabatic refocusing pulse applied 900 milliseconds before the label control module to new the Venus signal, and the turbo flash acquisition directly following the label control module. The whole sequence cost 3.6 minutes for a single label or control, or 7.2 minutes for the pair. A reference image without any preparations like labeling or spatially selective inversion was acquired with a thin acquisition TR for later quantitative analysis of the signals level. And time-of-flight reference scan was also acquired for comparison with almost identical spatial coverage at a higher resolution of 0.5 millimeter isotropic with 5 slides, total scan time 7 minutes. So representative VSMRA images of label control and the resulted angiograms from a single slice of one subject are arrayed here. The FTVSS is only labeling method that by itself yielded a clear angiogram with largely suppressed background. After subtraction of label control, all the other methods showed reasonable arterial signals. So orthogonal MIP images of arteriograms, including tau or various VSMRA methods from one subject are displayed here. All VS modules depicted the major arteries well. Compared to time-of-flight and FTVSS, the subtracted VSMRA, including DRT/8 or DANTI and FTVSI, delivered better delineation of small arterial branches with more suppressed background. This may be due to the more complete cancellation of tissue signal via subtraction. To quantify the relative signal or contrast ratios from main arterial segments, ROIs were drawn manually on the first and second segments of ACA, like A1, A2, MCA, M1, M2, and PCA, P1, P2, and their surrounding tissues. DRT and BR8 yielded very similar average relative arterial signal ratios, which were almost 40% lower than DANTI, which is 0.3436 versus 0.56, while their average relative tissue signal ratios were lower than DANTI 2, 0.00 versus 0.06. FTVSS with the labeling modules alone at half the scan time produced average relative arterial signal ratio of 0.39 and the relative tissue signal of 0.06. In contrast, FTVSI showed the highest relative signal ratios, 0.59, and the same low average relative tissue signal ratios as both DRT and BR8. So accordingly, the relative arterial tissue contrast ratios delivered by DRT, BR8, and FTVSI were slightly higher than those of DANTI and FTVSS. To conclude, the DRT and BR8 showed very similar labeling effects. The DANTI yielded a high arterial signal but with a residual tissue signal due to the spatial banding effect. FTVSS with half the time of the other techniques serve as an efficient non-subtractive VSMRA method with better delineation of small vessels and time-of-flight. And FTVSI produced the highest arterial signal in VSMRA, correlating with high labeling efficiency. That's the founding source.
Thank you, Dr. Da Pang. The paper is open for discussion. Are there any questions? If not, we can move on because of time constraints to the next speaker. It is Dr. Chen-Ri Chao from the Department of Radiology, Northwestern University and group. She will talk about high-resolution, time-resolved ASL-based 4-dimensional MR angiography using golden angle, radial sampling, and subtraction-based low-rank subspace reconstruction. Please go ahead.
Thank you for the introduction. This is the work from my student, Tianri Zhao. Unfortunately, he cannot make the trip, so I'm here to present for him. So Kim gave a very nice talk regarding the static ASL-based MRI. Now we're gonna move to dynamic ASL-based 4D MRA. So ASL-based 4D MRA is typically acquired using Cartesian trajectory with segmented multi-phase BSIP or symbioid gradient echo readout. So this generally results in relatively long acquisition time, especially if we push the spatial and temporal resolution and the spatial coverage. So recently, the 4D MRA is like accelerated ASL-based 4D MRA has been introduced by employing Stagostar golden angle radial trajectory. There are several advantages of radial trajectory compared with Cartesian. First of all, the oversampling in the k-space center and the incoherence allowed us to apply the constrained reconstruction using the undersample data. And also the radio acquisition offered relative insensitivity to the motions and basically can get a sharper vessel structure without pulsation-induced blurring. And another thing, the golden angle, because it allowed us to get different temporal resolution. Basically, we can combine the consecutive arbitrary number of consecutive golden angle spokes for the reconstruction. So there are several reconstruction methods that have been applied for the radial 4D MRA. The first technique, there shows a few examples, like the k-space weighted image contrast, the QUIC. This is a wheel sharing technique. I think most people are familiar with that. Basically, like the center of the k-space is filled by the spokes of the current phase, but the surrounding of the k-space actually gradually shared from the adjacent spokes, adjacent frame. So this can provide very good performance regarding the 4D MRA. And then the compressed sensing also is introduced to the 4D MRA. And for instance, the most promising reconstruction method is magnitude subtraction compressed sensing. And this make use of the sparsity of the magnitude subtraction between control and label. And this offer very good performance in terms of the image quality and the temporal dynamics. But the issue about all these reconstruction, because the temporal information actually present the temporal correlation, and all those methods actually don't use all this information, that causes the acceleration rate limited. Then the purpose of this study actually is to develop a fast, low-rank subspace, high-resolution 4D MRA, terms of flash 4D MRA, to achieve ultra-high temporal resolution, or basically very high acceleration rate, and to maintain reliable image quality without compromising the temporal fidelity. So basically the acquisition is still the same, using the Stagostar golden angle radio, but the image reconstruction, inspired by the previously developed self-calibrated low-rank subspace reconstruction, like GRASP Pro, which estimates the temporal basis, use the central region of the k-space, like low-resolution images. But our flash 4D MRA, basically we take the center point of the k-space subtraction between label and control. And then we group the data based on the temporal resolution we want to achieve and extract the temporal basis. And then we use the first k-dominant basis to decompose the label and control data and get the spatial basis. So basically the reconstruction becomes to optimize the following, to solve the following optimization equation. And you can see there's the spatial and temporal. The UK is the temporal basis, and the VK is the spatial basis. And in this acquisition, instead we only use the TV term along the spatial and the temporal domain, we also incorporate our magnitude subtraction as another constraint. And then we reconstruct the label control data simultaneous. So first question is how we determine the optimal K, right? So that's the number of temporal basis. And here shows the example, like if we use an extremely smaller K, like a K of 2, basically 2 compartment, and then we can see actually won't cover enough temporal information and cause some temporal blurring and lose some information. But if we use a very large K, like for instance K of 20, and you can see basically here shows very similar, but you still can get like increase the noise level because you get enough temporal information, but meanwhile, actually also involved a lot of noise. And to balance that, we use the K06 because we can achieve very nice image quality and without severe noise level. And meanwhile, the reconstruction burden significantly reduced. Here shows our results. And you can see the first row, we select a few frames, and then the dynamic shows on the left side, and you can see different views. And meanwhile, we also can get a very nice image between the label and control. Okay. And then we do the comparison between our flash MRA with other reconstruction methods like GRASP Pro, that's as I mentioned, is a subspace method. And the magnitude subtraction we proposed before, and the GRASP use the temporal TV because basically all these methods, except the magnitude subtraction, also involve the temporal correlation. Then we can see generally if we use the 20 spokes per frame or the temporal resolution is 100 milliseconds per frame, we can get pretty much similar results using different reconstruction methods. That means all provide very good image quality. Another thing keep in mind, because the subtraction also helps to reduce the noise or the same pattern of streaking artifacts. And then here shows the time courses from different ROIs. And we use the NOFT as the reference because basically that's without involve any temporal constraints. And you can see the purple is our method. Basically, it exactly follow the NOFT. But the graph, as I mentioned, that's going to induce a certain blurring. And then if we move to a higher acceleration rate, for instance, we only use the 10 spokes per frame. That's corresponding 50 milliseconds per frame. And we can see, actually, all the other techniques, the reconstruction methods, the image quality dramatically reduced. But our flash MRA actually still maintain a good image quality with the lowest noise level. Basically, you see the NOFT almost cannot get the image there. And then we can try different acceleration rates. The question is, can we really push very high acceleration rate? We can see this shows use 20 spokes per frame, 10 spokes, 5 spokes, and 3 spokes. And you can see even 3 spokes, all the image quality looks comparable. And even with very, very high resolution, 15 milliseconds per frame. And if you look at the right side, the original data images also looks pretty good without obvious streaking artifacts. And here we extract the time course as well. All the different acceleration also show the similar performance as well. So this gives another example. If we increase the spatial coverage, now we do the 64, basically cover the majority of the whole brain of the vessels. And you can see this also shows very good. And our acquisition time is 4 minutes in this case, but now we can push even 3 minutes, we can get the whole brain coverage. In conclusion, so Flash 4D MRA has demonstrated good performance in restoring both label control, original images, and subtraction vascular images as well. And the Flash 4D MRA overperformed other reconstruction techniques and in maintaining good image quality with a much higher acceleration rate. And the Flash 4D MRA can achieve extremely high temporal resolution, up to 3 spokes per frame, 15 milliseconds, without compromising image quality and temporal fidelity. So the future work, we can simply incorporate these techniques into the 3D acquisition, and we're also going to evaluate the feasibility of the Flash 4D MRA in clinical application. So at the end, I would like to thank the grant support and all the lab members from my group. Thank you.
Thank you very much. There's time for one quick question, please. So I want to ask you, I'm a radiologist, and the radiologists of your department, how do they do? The interventional radiologists, do they do for intracranial interventions before a digital subtraction angio, or are they, do they agree with your pictures?
That's a good question. So we actually now, Yeah, so I think you mean like, do we read the pictures before they conduct the like intervention treatment?
Before decision making.
Oh, before decision making. I think currently people still based on the DSA, but our goal actually we want like provide like at least like a comparable image quality with the DSA, and we have like the old works and we do the comparison. I think the results actually like comparable with the DSA. I hope in future like a clinical we're gonna do more clinical evaluation, and hope this can guide like to make a decision.
Thank you. So let's move on to the next presentation. It is given by Dr. Dan Chu from the Johns Hopkins University, Baltimore, Maryland, with the title Rapid 3D Velocity Selective Head-Neck MRA with improved background suppression and reduced sensitivity to slow arterial inflow. Please.
Okay, thanks for introduction. I'm Dan Zhu. I'm from Kennedy Krieger Institute, and I have nothing to declare. So the MRA of the head and neck is of great clinical value for the diagnosis of carotid and intracranial arterial disease. Existing non-contrast enhanced MRA such as time of flight, ASL, QLASH, and KEYS are time-consuming. Recently, our group developed a rapid 3D head-neck VSMRA with an isotropic resolution of 1 millimeter in about 1.5 minutes using the efficient stack spiral acquisition. In this work, we further improved the head-neck VSMRA with better background suppression and reduced the sensitivity to slow arterial inflow, which is often observed for elderly subjects or patients with stenosis. So the original head-neck VSMRA is a VSS Olin scan, which starts with a pre-delay of 460 milliseconds for signal recovery. Followed by a slab selective inversion pulse with an inversion delay of 900 milliseconds to null the venous signal, and the fresh arterial blood flows into the brain during the delay. A Fourier transform-based velocity selective saturation pulse train was applied immediately before saturation and image acquisition, with a cutoff velocity of 1 centimeter per second to suppress the static brain tissue. The 3D acquisition employed a segmented stack spiral turbo flash readout for fast image acquisition. This protocol is a non-subtractive that requires only a VSS prepared image. It takes only half the scan time compared to existing subtractive MRA like ASL, but the background suppression could be hampered by T1-induced bias due to recovering during image acquisition. According to our previous analytical theory, we improved the background suppression by subtracting the T1-induced bias obtained through an additional non-selective saturation prepared image with identical acquisition. The NSS prepared scan only adds little extra time rather than doubling existing subtractive MRA. One limitation of the current approach by exerting an SSI pulse with a delay of 900 milliseconds for nulling the venous blood is its susceptibility to slow arterial inflow for elderly subjects or patients with stenosis. To overcome this limitation, we propose a new VSS saturation recovery VSS-SR sequence with increased inversion delay. The venous signal in VSS prepared image would recover during the increased TI. By adding the proper saturation delay after the NSS pulse, the venous signal in VSS prepared image could be set lower than the venous signal in SR prepared image recovered during the saturation delay, resulting in a non-positive difference. In this work, the saturation delay was set to 350 milliseconds for a preliminary study. Experiments were conducted on a 3T Philips scanner, and the VSMRA protocols were evaluated on 8 healthy subjects. with a large foot head coverage of 300 millimeter and an isotropic high resolution of 1 millimeter. This slide demonstrates a comparison of the VSS Olin and VSS minus NSS protocol. For VSS Olin, the VS MRA with a long acquisition window shortened the scan time at the cost of a CNR loss. The VSS minus NSS with a long acquisition window has more complete background suppression, resulting in 60% contrast to noise ratio increase. This figure compares the coronal and sagittal MIPS of the VS minus SR and the VSS minus NSS sequence on a healthy young female with fast blood flow. Compared to VSS minus NSS images, the VSS minus SR images demonstrates greatly improved cerebral arteries signal. And here's another subject which is 63-year-old and has relatively slow blood flow. We can see that the basilar and the vertebral arteries are merely seen in the VSS minus NSS scan, but the VSS minus SR images greatly improved the depiction of the vertebral and basilar arteries. In this work, we achieved better background suppression and with VSS minus NSS for a 3D head neck VSMRA with a similar 1.5 minutes scan time compared to VSS Olin, as well as VSS minus SR scan in about 2 minutes, reducing sensitivity to slow arterial inflow. A low sense factor of 2 was used without any partial Fourier, so this technique is capable for further acceleration, such as compressed sensing and deep learning. And thank you for your interest, and I'm open for questions.
Thank you very much. The paper is open for discussion, please. Are there any questions? If not, I, as a radiologist, want to ask, you showed us pictures from the aortic arch, and of course the aortic arch and the origins of the supra-aortic arteries have to be included in the imaging. But I never saw a good delineation of the origin of the carotids or the vertebral arteries. Can you comment on this?
Sorry, could you repeat the question? So,
yes. I'm a radiologist and coming from the interventional radiology. And if I plan an intervention, I want to know if there is a high-grade stenosis at the origin of the common carotid artery coming from the aortic arch. Do you see this with your method?
This is only a study on a preliminary study on healthy subjects. We haven't done any patients, but we are now searching for collaboration with radiologists, and we have planned to scan some patients with we want to do scores on the patients with stenosis, and we want to see compare it with contrast enhanced image to see if we can do this scoring on our new method.
Thank you.
Thank you.
And now I want to hand over to my co-moderator, Jean Go, from the University of Washington.
Yeah, thank you. And let's welcome our next speaker, Dr. Xu Ning from Tsinghua University. And she will introduce us a 3D large coverage carotid quantitative imaging solution. Yeah, let's go ahead.
Okay, thanks for your introduction. Good morning to our attendants. My name is Ning Xu. I'm a PhD student from Center for Biomedical Engineering Research, Tsinghua University. It's a great honor to stand here to introduce my recent work on carotid vessel wall quantitative imaging. So it composed of a protocol and the post-processing pipeline related to each images. So the rupture of coated atherosclerotic plaque is one of the leading causes of ischemic stroke. Lipid-rich necrotic core, intraplaque hemorrhage, and thin fibrous cap and so on are the vulnerable characteristics of plaque. Multi-contrast high-resolution vascular MRI image can characterize plaque compartments and facilitate the assessment of plaque, which is of great significance for the prevention of ischemic stroke. Recently, quantitative imaging such as T1, T2, and T2 star mapping derived from multi-contrast MRI image has shown its feasibility in identification and segmentation of plaque compartments. Quantitative information can better characterize plaque compartments and has a great potential in stratifying vulnerable plaques. Black blood VWI and the bright blood MRI are recognized as the optimal protocol for plaque characterization. Large coverage imaging is essential for plaque blood burden assessment and distribution detection. However, time efficiency has to be taken into account in terms of acquisition and fitting time. Thus, sequence optimization and post-processing pipeline development is essential. In this study, we propose a 3D large coverage coated quantitative imaging solution and an efficient post-processing pipeline and validate its feasibility. So here comes the method part. Adopted from the published black blood multi-parameter VWI sequence schema, our work introduced bright blood image to this protocol. There are 5 scans in the protocol with different duration of RMC pre-pause and flip angle during acquisition, excitation. According to the SPGR steady state equation, the scan 1 and 2 with different flip angle can fit T1 value, while the scan 2, 3, 4 with different duration of MIC pre-pause can fit T2 value, while the scan 2, the scan 5 with different time of echo can fit T2 star value. The blood signal was maintained in scan 1 and 2 by removing the MIC blood suppression pre-pause in schema. In this way, the T2 prep duration of scan 2 is equivalent to 0, which will not affect the calculation of T2 value. Also, the longitudinal coverage was extended to 140 millimeters to cover both intracranial and extracranial carotid artery, and the resolution was improved from 0.98 ISO to 0.6 ISO. Correspondingly, radio trajectory and compressed sensing was applied to achieve downsampling. AP direction was broken to reduce scan time. So here are the scanning parameters of the imaging protocol. The B1 map was acquired to correct the B1 field homogeneity. The total scan time of the protocol is around 60 minutes. So considering the workload of global fitting, we propose an MRI-guided post-processing pipeline to perform registration and generate local patch. The lumen information of scan 1 can clearly localize vessel area, and which is useful for the registration of dynamic scans and the local patch generation. So there are 4 steps in the pipeline. First, scan 1 was roughly aligned to the scan 3 by a rigid registration. Then the lumen area of scan 1 was segmented using lever-side-based algorithm. Center line can be extracted after this step. Third, local vessel will be spline registration between 1 to 5 images were performed using a circular mask of 10 millimeters generated by the center line. Finally, T1, T2, and T2 star mapping of the operator-determined patch around the lumen area in scan 1 to 5 was estimated. So Phantom experiments were performed to validate the accuracy of the proposed method. Phantom we use the standing mapping for comparison, such as inversion recovery spin echo for T1 and spin echo for T2. In vivo studies were performed to validate the feasibility of the protocol and pipeline. So 4 healthy volunteers were recruited in these studies. All the experiments were performed on a 3T Philips MR scanner. So here comes the result part. As is shown in the figure, the quantitative protocol has had an excellent agreement with the standard maps, imagine T1, T2, and T2 star values. The correlation of T1, T2, and T2 star values measured by the two methods was assessed by linear regression. The R-square suggests that the proposed sequence is consistent with the standard sequence. The differences in the quantitative parameters value of cervical muscle measured on the proposed protocol and the standard mapping sequence in volunteer experiments was assessed by the peer t-test. No significant difference were found in T1, T2, and T2 star value between the two sequences, and the value of the carotid vessel wall of healthy volunteers are shown here, which are consistent with the previous research. Large coverage carotid vessel wall images acquired and analyzed by the proposed solution are shown in figure 4, demonstrating the feasibility of the protocol. In this work, we updated the published black blood quantitative VWI protocol in sarcoma to a large coverage and introduced bright blood image to the framework to provide more blood components information. Meanwhile, the lumen location derived from bright blood image was applied to the post-processing pipeline to guide local patch generation, which can further reduce fitting workload of large amount of data. Also, we validate its feasibility in accurately evaluating carotid vessel work. So there's still more work on this proposed method, for we need to recruit more volunteers to examine the accuracy of the protocol, and interleaved acquisition are needed for self-registration to eliminate motion between scans. Also, downsampling strategy has to be considered in this protocol. Okay, thanks for your attention. That's all.
Thanks for the introduction of this quantitative imaging solution. This talk is now open for questions.
Very nice talk, very nice work. Really think that the approach with high resolution and large coverage is very important. And I was just wondering whether you could comment on the fact that it takes separate scans and over 16 minutes of scan time, whether that could potentially be a barrier for clinical adoption.
Oh, yes. Thanks for your question. In this protocol, we just validate the feasibility of this protocol. So as I have mentioned in my future work part, there's still more work we have to do on the downsampling of this protocol. For there are 5 scans in this protocol. So we are considering about the sharing information between the scans, since the image was acquired based on the SPGR equation. So there are many shared information between the 5 scans. So there are 2 approaches. First, if we consider more clinical application feasibility, we can use compressed sensing to do more work. Also, if we want to because we have to consider about clinical application, if we use patch to update some work, we have the low rank restriction, so we need to recount the data offline. So it's it's a trade-off between clinical application and it's the technique improvement.
Okay, thank you.
Yeah, thank you. Just a quick follow-up. Okay, then let's move on to the next talk. Let's welcome Dr. Zhengsen Chen, introducing from Fudan University, introducing accurate segmentation of cerebral vasculature on 4-dimensional ASL magnetic resonance angiography.
Okay, thank you for the introduction. So this work is mainly performed by Wei Bin Liao from Beijing Institute of Technology, and I will give the presentation on his behalf. So this talk is mainly about the segmentation of the cerebral vasculature based on the 4D ASMI. So I have nothing to declare, sorry. So we all know that the segmentation of the cerebral vasculature is useful for statistical planning, quantitative disease evaluation, and development of the normal imaging markers. For example, our previous study shows that the morphological features of the intracranial vasculature can be a potential marker for vascular aging, and it's associated with cognitive impairment. But it's difficult to achieve fully automatic and accurate vascular segmentation based on the conventional MR vascular images, such as the TOF MRI, because of the insufficient image contrast. And the arterial spleen labeling for the MRA has the potential to better visualize the distal cerebral arteries. And if you look into the image here, we know that for each voxel, the vascular for each voxel there is a time course, and if you compare the signal for the background and the vessel, you will see they differ very large in not only in the signal intensity but also in the shape of the time course. So we believe this feature will be very helpful for the vessel segmentation. So in this study, we aim to propose and evaluate an accurate and robust machine learning approach for segmentation of the intracranial vasculature based on the 4D ASO MRA. So we included, this study included 18 subjects, 14 healthy subjects, and 4 myelopathy patients. The 4D ASO MRI image were acquired with the iSNAP sequence, which essentially is an parse ASO based MRI sequence, and use a 3D golden angle radio gradient echo readout, and it reconstruct the dynamic images by using the view sharing reconstruction techniques. And this sequence basically have a whole brain coverage and has a temporal resolution of around 200 milliseconds and 0.8 isotopic resolution. So we use the unsupervised machine learning approach for the segmentation. And the method we use is the isolation forest, which is an outlier detection algorithm. The basic idea is you can construct trees to and random select features and the specific value to isolate each data sample, and then you can construct many trees. And for the outlier, you will see you will have a shorter path for this isolation, and for the normal samples, you will have a longer path. So the advantages of this method is that it's unsupervised and is very good for the unbalanced data sample size. So in this study, the vascular voxels are considered the outlier because they only account for less than 1% of the brain imaging. Here are the features we extracted from the 4D ASO MRI. So basically, for each time course, we extract the several features such as the intensity and the width of the bolus and the number of peaks and so on. And we also converted the 4D image into a single 3D images by performing a maximum intensity projection along the temporal dimension, and then we extract the mean standard value and the maximum and minimum signal intensity for each voxel in their neighborhood. And because we have 2 cohorts, so we train 2 models, one for the healthy subjects and one for the myelopathy patients. And the training was performed on a single subject, and the evaluation was performed for all subjects. We used the Dice coefficient and Hausdorff distance and the total length of the vessel center line to evaluate the performance of the models. And to get the Dice and Hausdorff distance, we randomly generate we randomly generate cross-sectional images and have an expert to manually draw the contours. Here is a representative result. So as you can see, for both the large, intermediate size and small size arteries, the the DICE score is quite high. And this slide shows the benefits of combining the temporal and spatial features. So here we only look into the intracranial part. So as you can see, combining the two types of features can allow better identification of the small arteries and avoid the discontinuity in the final segmentation. And the statistics also show the best performance for this type of features. And we also look into the importance of the different features for the segmentation. And you can see that the temporal features actually play more importance in the segmentation. To evaluate the robustness of the model, we also compare the models between trained on a single subject and on all subjects. And this is about the total length, and here are about the DICE and the half-stop distance. We can see that there is no difference or very small difference between the two models. But the training time will be proportional to the number of subjects included. Here is a comparison of the models trained on healthy subjects and Moyamoya disease patients, and we can see the healthy subject model will perform better than the MMD model for the healthy subject data. And this is similar for the Moyamoya disease data. So in this study, the 4D ASMI has a large image contrast between vessels and static tissues. And we found that a simple machine learning approach utilizing appropriate features can effectively segment the cerebral vasculature based on 4D ASMI, and there's no need of the label data, and the training can be performed on a small number of data sets. And it might be necessary to train the segmentation model individually for the different cohorts if they have different flow characteristics. And there's still room for improvement. For example, some distal arteries which are very close in space, they may be wrongly connected in the final segmentation. So some cleanup or improvement of the algorithm may be needed in the future. We would like to thank our funding support, and thank you for your attention.
Thank you, Dr. Chen. It's very impressive result, especially given that it's unsupervised nature. This talk is open for questions. And then I have a question. So I think it's very essential to use this temporal features to do the segmentation. So do you think only using the spatial features, this method can also work well for like static 3D MRA or like TOF-based MRA, like the applications in yesterday's challenge? Do you think this model can work well?
I think if for we didn't try that because for the TOF MRA, basically we already have very many other methods, especially like the ULED, which were mentioned yesterday. So if you only use the spatial features and with the simple machine learning approach, that would, I guess it will not achieve a good result as compared to the state-of-the-art methods. But for our imaging, because we have the temporal information, so the simple machine learning approach may be feasible.
Yeah, thank you.
I have a quick question.
Yeah, sure.
So, so what's your input? Your input gonna be the 4D whole volume? Or you do the patches? Because I'm thinking, do you need any data augmentation?
The algorithm actually is voxel-wise. So basically, you extract the features for each voxel, and then you input the model.
Oh, so that's similar like the moderator's question. You didn't use the spatial information, right?
We did use the spatial information because for each voxel we also consider its neighbor, like a 6 neighbor or 26 neighbor, and you use the mean or maximum or standard deviation of the signal within this neighbor, but only a small neighborhood of the voxel. Yeah.
Okay, thank you.
Thank you.
Thank you. Let's move on to our next talk. Let's welcome Dr. Lixing Liu, and she will introduce comparison of ISNAP dynamic MRI and time of flight MRI in visualization of cerebral vessels. She is also from Fudan University.
Well, thanks for the introduction. And hello everyone, I'm Lixing Liu from Fudan University. It's my pleasure to introduce our work here. And I will talk about comparison of ISNAP dynamic MRA and TOF MRA in visualization of the cerebral vessels. And this is my declaration. I have nothing to disclose. As well known, TOF MRA is widely used to visualize the cerebral vessels and evaluate the cerebral vascular diseases. However, the vessel signals on TOF is highly dependent on the direction and the velocity of the blood flow. So it may result in the compromised depiction of the distal and the collector vessels. And this figure shows the DSA and TOF of a patient with a Moyamoya disease. We can see that compared to DSA, TOF doesn't depict most of the right MCA collector vessels, and is not conducive to the diagnosis and the treatment of the Moyamoya disease. And we know that dynamic MRA records the flow of the blood like DSA, so it may help to visualize more distal and collector vessels. And the SNAP sequence can obtain a dynamic MRA image with a high spatial temporal resolution. And this sequence consists of an ASL preparation followed by a 3D golden angle ratio spoiled gradient echo readout. A small slab and a large slab inversion prepouts were performed alternately, and the DMRA images were constructed by using the quick with a small temporal window width and small numbers of the rings to minimize the temporal blurring. And the SNAP DMRA images has a whole brain coverage and a high spatial temporal resolution. However, no work has been reported to evaluate the capability of the SNAP DMRA for visualizing the cerebral vessels. So in our work, we aim to quantitatively compare the cerebral vessel visualization between TOF and SNAP DMRA in both healthy volunteers and the patients with Moyamoya disease. And in our work, 17 healthy controls and 9 MMD patients were included. And the MRA was performed with a 3D scanner of engineer of Philips. And the detailed protocol is shown in this table. For data analysis, SNAP DMRA images were registered into the TOF space to ensure the same FOV for every subject. And the vessels on TOF were segmented by a trained NU-net. This is a deep learning network and widely used in medical imaging segmentation and performed robustly for many types of images. And the vessels on SNAP DMRA were segmented by an unsupervised outlier detection method. And we know that vessel signals on DMRA experience an upslope at some time point and a downslope later. Of course, there may be a planned phase in between. On the contrary, the background voxels are featured with random intensity, and that is much lower than the vessel voxels. So this unsupervised segmentation method extracts temporal features from the voxel signals, and the voxels in the neighborhood were used to extract spatial temperatures. And vessels can segment by using the two type features. More details about this segmentation method have been reported by the last speaker, so I won't introduce too much here. And now the vessels on SNAP DMRA and TOF MRA were segmented. And then we extract vessel center length and calculated the total vessel center length. And because the length of the vessel center length were normally distributed, so parity test was used to compare the total vessel length between TOF and the SNAP DMRA. Here are some sample results. And the two fingers shows the vessel segmentation and the MAP of the SNAP DMRA and TOF MRA. And the left finger is for two healthy controls, and the right is to MMD patients. To make sure the fair comparison, the wings of the SNAP DMRA segmentation have been manually removed. And firstly, we can see that the vessels on SNAP DMRA and TOF MRA were well segmented for both healthy controls and MMD patients. And the SNAP DMRA shows more vessels than TOF, especially for the posterior circulation. That is an important vessel structure for MMD patients because it's may associated with ischemia and the bleeding. And SNAP DMRA can depict it better. And this is a Weiling finger for vessel length comparison. We can see that the total vessel length of the SNAP DMRA was significantly longer than TOF. It may suggest that SNAP DMRA may depict more more distal and collateral vessels. And to the summary, we found that SNAP DMRA is superior to the conventional TOF in visualization of the distal and the cerebral vessels for both healthy volunteers and the patients with moyamoya. And it suggests that SNAP DMRA may have more potential for evaluate small vessels in patients with cerebral vascular disease. And of course, in clinical settings, the gold standard of the angiography is still DSA. So we will further evaluate the capability of the SNAP DMRA for visualizing the collateral vessels in MMD patients by comparing with DSA. And finally, I'm very grateful for the help from my lab members. And that's all about my talk. Thanks for your attention.
Yeah. Thank you for this talk. And now it's open for question.
So I have a question. Very impressive images. Thank you so much. But what about combining your method with the perfusion method so that you can see the areas where there is minor perfusion?
Sorry, could you repeat a little slower? Could you repeat it?
What about your method in clinical practice to compare with the perfusion of the brain?
Well, I think, of course, we didn't do that, but I think we can collect more MMD patients data sets and do the comparison. And we are also looking for the cooperation. If have a chance, we can have a cooperation. Thank you.
Yeah. Thank you for the talk. And now let's move on to our power pitch session. So each speaker will have 3 minutes to present their work, and the audiences are also welcome to go to their poster to further discuss their work. At first, let's welcome Dr. Ning Jin, and she will, from Siemens, she will introduce feasibility of compressed sensing accelerated 3D phase contrast for magnetic resonance phonography.
Thank you for the introduction. I'm going to present our preliminary work of the compressed sensing accelerated 3D phase contrast for MR resonance phonography. The purpose of the study, first, MR phonography is a non-invasive technique for the visualization of a cerebral synapses. 3D phase contrast without ECG gating is a technique has been used for MRV imaging. Conventional parallel acceleration will lead to long acquisition time due to large coverage and high spatial resolution. Compressed sensing has been developed to accelerate image acquisition. So the purpose of the study was to evaluate the feasibility of a compressed sensing accelerated phase contrast technique for MRV. For the method, we enroll 5 healthy volunteers and scan on the 3 Tesla magneton Vita. CS accelerated phase contrast sequence was used, is a 3D phase contrast sequence, and the sampling pattern is shown here with a variable density, golden means under sampling pattern, with a center of region fully sampled for the coil sensitivity estimation. For imaging protocols, are listed here. The similar protocols are used between GRAPPA and CS. For GRAPPA, we use rate 2 acceleration. For CS, we use a rate 8 acceleration. So total acquisition time is about 5 minutes for GRAPPA and about 2 minutes for CS. So let's look at the results. Here are the 3 MIPS from the 3 healthy volunteers. The first row is acquired with the GRAPPA rate 2 acceleration, and the second row is acquired with the CS rate 8 acceleration. GRAPPA and the CS phase contrast MRV MIPS show similar image quality, though CS phase contrast MRV images were slightly noisier. Superior sagittal sinus and the transverse sinus were well visible in both techniques. And compared the techniques, CS significantly shortened acquisition time compared to the conventional GRAPPA acceleration. So in conclusion, we demonstrate the feasibility of the CS accelerated phase contrast MRV, and compared with the conventional technique, is significantly faster and reduce acquisition time and preserve image quality. It's a very preliminary work. I think we need to look into how it works in the patients, and maybe we should optimize the protocol to make the image better. Thank you for your attention.
Yeah, thank you, Dr. Jin. Now let's welcome Dr. Jiaqi Dou from Tsinghua University. She will introduce in vivo T1 mapping for quantitative evaluation of intracranial atherosclerotic plaques.
Thanks for the introduction. Hello everyone, my name is Jiaqi Dou. I'm a PhD student studying at Tsinghua University, and I will introduce our abstract, in vivo T1 mapping for quantitative evaluation of intracranial atherosclerotic plaques. I have nothing to disclose. Intracranial atherosclerosis is one of the major causes of stroke, and high-resolution MR techniques enabled imaging of intracranial atherosclerotic plaques in vivo. Given the small size of intracranial vessel walls and the long acquisition time of conventional motivated MR vessel wall images, in vivo T1 values of intracranial plaques have rarely been reported. A 3D snap with golden angle radiocase-based sampling sequence for measuring T1 values of carotid vessel wall showed capability in characterizing vulnerable carotid plaques. We extended this sequence to intracranial vessel walls and generated in vivo T1 mapping to quantitatively evaluate the intracranial plaques in symptomatic and asymptomatic patients. 16 patients with MC atherosclerotic plaques were included in this study, including 10 symptomatic and 6 asymptomatic patients. Intracranial arteries of all subjects were imaged on a 3D scanner, and a 3D TOF MRI was performed to identify the location of the MC's stenosis. 3D T1 VISTA and 3D GoldSnap images for T1 mapping were also acquired. The most stenotic layer of each patient was chosen for quantitative analysis. Manual delineation of the 2D plaques were performed using Cascade. Then the mean T1 values of each plaque were calculated. We performed the delineation and T1 calculation on the GoldSnap black blood vessel wall images. Overall, symptomatic patients showed a significantly lower intraplaque pre-contrast T1 value compared to the asymptomatic patients. In this figure, we show 2 plaques with similar signal intensity on T1 VISTA images, while T1 values of the symptomatic plaque were considerably lower than those of the asymptomatic plaque. In conclusion, we investigated the T1 values of in vivo intracranial atherosclerotic plaques in this study. Symptomatic patients showed lower T1 values compared to the asymptomatic patients, possibly related to potential plaque components such as lipids and hemorrhage. The feasibility of in vivo 3D T1 maps were also evaluated. 3D pre and post T1 maps as well as 3D enhancement maps were calculated. More patients will be recruited for further validation. That's all. Thank you for your kind attention.
Thank you, Dr. Do. Finally, let's welcome Dr. Akihiro Manabe from Siemens to introduce influence of effective TE and contrast in background suppression diastolic MRI without subtraction using variable flip angle 3D TSE. Welcome.
Thank you, Chairman. I'm Akihiro Manabe at Siemens Healthcare Japan. I have this presentation instead of Mr. Kagami, since he couldn't attend this meeting. For introduction, non-contrast enhanced MRA using variable flip angle 3D TSE generally acquired subtractions. It uses, as you know, it uses the flow void effect, but it may sometimes resulting in misregistration like here, so it's caused by turbulence and slow flow or and so on. Therefore, so we consider the optimal setting value by modifying effective TE to visualize artery without the need for subtraction. This is a method. So by 3 Tesla MRI scanner, VRFS 3D TSE in the pelvic region was scanned in the diastole with effective TE varied from 42 to 201 milliseconds at approximately 20 millisecond intervals. So then we measured signal values of artery, vein, bone, and muscle from the obtained images and compared the average value. And we also compared the contrast ratio of artery and vein and artery and muscle. This is the results for the two. So at one, the signal values of bone were always low, and those of muscle were similar to bone at effectivity of 140 milliseconds or longer. Next, that longer TE is increased CR by approximately 1.5-fold for artery divided by vein, and approximately 1.4-fold for artery divided by muscle. So that by prolonging the effectivity, so like here the images, so we use the optimal setting for the signal value of the artery become hyper intense compared to the background and vein, likely due to differences in T2 value and flow void effect. It suggests a potential to eliminate the need for subtraction, thereby simplifying the process and reducing process possible error. Finally, so we suggested this one, so background signals suppressed and artery predominant images can be obtained. And we have devised a method called Basara. It's Japanese word for the strong style. Applied it to clinical practice. So it's here is the images, so we can set the various regions. So thank you for your attention.
Yeah. Thank you, Dr. Manabe. And I think this concludes our education and scientific session 6, acquisition, reconstruction, and processing neurovascular. Yeah, thank you all the speakers for delivering all these exciting talks and being very on time. And also thanks audience for the interesting questions. And I think we can head to the coffee breaks, and we will reconvene at 11:05.